Today in the OPD, I had a patient with known antiphospholipid antibody syndrome with a history of thrombosis, now coming with on warfarin, now coming with a breakthrough thrombosis. So we will discuss breakthrough arterial or venous thrombosis in APS despite therapeutic warfarin compliance. I am Dr. Neeraj. So when a patient experiences a breakthrough thrombotic event, either a venous or an arterial occlusion, in a patient who is supposed to be taking warfarin, you are facing an absolute hematological emergency. Before assuming a pharmacological failure, you must methodically disentangle the pseudo-resistance trap, which is subtherapeutic dosing masked by laboratory artifact, from a true biochemical resistance. So, unmasking the lupus anticoagulant trap is your immediate operational action at the bedside is to audit the validity of a recent INR which shows you in the therapeutic range. The pre-analytical mechanism here is lupus anticoagulant is an in vitro inhibitor of phospholipids. So, standard all laboratory PTNR assays rely on commercial thromboplastin reagents that contain a lot of phospholipids. Strong circulating LA antibodies bind to these assay phospholipids and artificially prolong the PT and the clotting time. This artifact causes the laboratory machine to print a high INR, while in reality, in the tissue level, in vivo, the anticoagulation is profoundly subtherapeutic. So, what is the solution? The chromogenic factor 10 assay is the solution. So, to get around this issue, immediately discontinue tracking the INR, prothrombin time with INR. Order a chromogenic factor 10 assay. This enzymatic assay measures the actual functional concentration of factor 10 protein, which is completely independent of the phospholipid interface. What do you target then? A chromogenic factor 10 level of 20 to 30% confirms true therapeutic vitamin K antagonism. If the level is above 35 to 40%, it is pseudo-resistance due to subtherapeutic state of the warfarin dose. And it should be escalated despite the standard INR printout which shows a high value. Now, what is the antithrombotic escalation matrix? If the chromogenic factor 10 assay level confirms that the patient was truly therapeutic at the time of the breakthrough event, you have established true warfarin resistant APS. You must immediately escalate the antithrombotic regime. So, what is the thing that you can do? You will switch on to a discontinue warfarin and switch on to low molecular weight heparin. That is the pivotal change that you should do, because no longer warfarin is reliable to give this patient a antithrombotic window. Start with enoxaparin, dosed strictly to twice daily, 1 mg per kg every 12 hours. Why twice daily and not once daily? Because once daily profiles leaves a valley, a trough at hour 18 to 24, where the aggressive antibody driven antithrombotic engine of APS can break through and produce a new thrombus. And then how you surveil this? What is the surveillance pattern? Do not dose blindly. Titrate the LMWH based on the peak anti-10A level drawn exactly 4 hours following the third or the fourth consecutive dose, targeting aggressive therapeutic envelope of 0.8 to 1.2 international units per ml. Of course, this should not be stopped at that. High intensity warfarin can also be alternatively used. If long-term patient is reluctant to take the LMW, or there is an insurance failure where the patient can't afford it, you can go for a high-intensity warfarin with a INR targeted to 3 to 4, heavily cross-referenced against a chromogenic factor 10 line, because it is already ditched us. Upregulating endothelial and cellular defenses are the next one. Because APLA antibodies stimulate multiple cellular structures simultaneously, managing refractory breakthrough requires upgraded anticoagulant with structural, metabolic and anti-inflammatory modifiers. High-dose hydroxychloroquine 200 mg to 400 mg per day, or in a dose of 5 mg per kg, it disrupts endosomal toll-like receptor TLR7 and TLR9 signaling in monocytes. This prevents the detachment of protective annexin A5 shields from the endothelial membrane and directly lowers the APL antibody titers over long-term compliance, not acutely. High-intensity statins initiate atorvastatin at 40 to 80 mg despite the cholesterol level. Statins directly downregulate the endothelial tissue factor expression and inhibit vascular cell adhesion molecule, or VCAM1, blunting the vessel wall's capacity to initiate a clot when hit by an antibody wave. Next, screen for catastrophic antiphospholipid antibody syndrome. Any patient with established APS who break through a therapeutic anticoagulant maintains immediate and continuous surveillance whether this is transitioning into a catastrophic antiphospholipid antibody syndrome, which can be life-threatening. The CAPS treatment bundle is not the same. When 3 distinct organs or tissues tracking simultaneously within a 1-week window is getting affected, you are dealing with a catastrophic antibody syndrome. Triple therapy protocol should be initiated with no delay. Maximal anticoagulation, continuous therapeutic unfractionated heparin infusion. Along with that, give pulse dose of corticosteroids, preferably methylprednisolone 1 mg per kg IV daily for 3 days. This should halt the cytokine storm, but that should not end it. This should be followed by a PLEX, plasma exchange, or an IVIG daily. Daily PLEX for 5 to 7 days with fresh frozen plasma. Replace or physically strip the pathogenic triple positive IgG antibodies and cytokines out of the circulation. And if the patient is still resistant, you can think of a complement blockade by eculizumab. If refractory, add anti-C5 monoclonal antibody eculizumab to halt the terminal component cascade driving the microangiopathic tissue injury. So to summarize, when presenting a complex failure profile in the morning rounds of an APS patient on anticoagulation, 4 critical checkpoints should be there. Ditch the standard INR order today. Verify that we no longer follow the INR, but instead write chromogenic factor 10 assay to evaluate. Enforce a split dose low molecular weight heparin of 1 mg per kg per day every 12 hourly to eliminate the trough coverage drops. Add atorvastatin, add hydroxychloroquine within the hour. Do not wait for the next clot to stabilize the endothelial wall. The action may start later, but definitely you will get a prolonged effect. Audit the blood smear daily for schistocytes. Actively look for a microangiopathic hemolytic anemia change or a sudden drop in platelets combined with schistocytes signal you are going to a catastrophic antiphospholipid antibody syndrome wherein you should call in steroids and PLEX.